so much for that wonderful introduction. Didn't help with my imposter syndrome, but still. So my name is Christofer. That's the Swedish pronunciation of Christopher. I'm a pathologist, and I have been asked specifically to talk about parathyroid lesions and some current dilemmas that we face every day when we diagnose parathyroid lesions. But I will also do a brief cover-up of where we are at in endocrine pathology as a subspecialty. So I have no scientific disclosures, but I have one disclosure that I would like to bring to your attention first. And this is very personal to me because this is my great, something like that, grandfather in the center with an arrow in his neck. Does anyone recall this painting? It's from English soil. It's a battle in 1066, and it's not Hastings. This is the Battle of Stamford Bridge, and the man in the dead center is my relative. So my father did the genealogy. My mother is Norwegian, my father is Swedish, so that's a common mix in Scandinavia. And this guy had 40 wives and 40 concubines, so he's like the Genghis Khan of Scandinavia. So he's also my relative, and here he is. He was actually killed by an arrow through the neck in the Battle of Stamford Bridge, which is kind of ironic because it was the end of the Norwegian War for the English throne, but it also serves as a beautiful example of the first recorded attempt of a core needle biopsy of the thyroid gland. So I have a personal conflict of interest because I still think I have a claim on the throne of England. I'm not sure if I'm allowed to say that, but anyway. So this is the disposition. So what is endocrine pathology and why do you need an endocrine pathologist? Before we go further into the realm of parathyroid tumors and the current dilemmas that we face. And of course, a summary. I'll try to be brief. I'll try, because I know we have some 15 minutes lag, so I'll try to keep a short leash here on the histology. So first of all, know your audience. This is very important when you lecture, especially when you're a pathologist standing in front of several hundreds of endocrine and ENT surgeons. So when I emailed Dr. Waghorn and I asked, so I assume the audience will be more than 95% surgeons? The reply was, sadly, yes. So with that said, I promise to keep the H&E slides to a minimum. Promise. Just enough histology to allow you to impress your residents during the ENT boards. And finally, I will deliver them surgeon-friendly, 1 cell per centimeter. So nice and easy on you guys. This is my all-time favorite movie. Of course, it's British. This is Monty Python's Life of Brian from 1979, the year I was born. And in this scene, the protagonist here in the center, he is the leader of the Judean People Front, and he hates the Roman occupiers. So he rhetorically asks the audience in the room, what have the Romans ever done for us? Unfortunately, he gets a reply from one of his members stating the aqueduct, followed by sanitation, roads, irrigation, medicine, education, wine, public bathhouses, law and order, and even peace. So this was not what he expected. So in a similar context, I would like you as surgeons, because I know sometimes you might wonder, what have endocrine pathology ever done for you guys? Well, in a similar way, to answer that, correct diagnosis, of course, this is the backbone of what we're doing. Prognostication, grading of tumors, staging of tumors as well, clues to hereditary syndromes. Endocrine pathologists can actually give you a clue to an underlying syndrome using histology alone, or even in combination with immunohistochemistry, or of course genetic information as well. We can identify unrelated disease that's not known at the time of surgery. We can also identify potential actionable genes that are good enough to use as targeted therapy. We can give you an indication of the margins, of course frozen sections, and we are always driving research in endocrine tumors. So with that said, I would like to sort of remove the image of the pathologist as some weird old guy standing in front of a corpse dissecting it, because this is what when I tell medical students about pathology, this is the image they get. But in real life, pathology has changed. Now, we rarely do autopsies, at least not in Sweden. We do in-depth molecular, histological, and immunohistochemical characterization using our hands, our eyes, to give the best optimal diagnosis, prognosis, and also treatment option to the patient. So with that in mind, as Sir William Osler once said, as is your pathology, so is your practice. Endocrine pathology is now at the front line in several different aspects. We are rushing towards a molecular-based characterization of thyroid cancer. For those of you who have read the 2022 WHO classification of thyroid neoplasms, you know that we're now trying to conceptualize this by dividing the follicular variant PTC into BRAF-like and ROS-like types, because basically they're two different things. One is a tumor that is a true papillary thyroid carcinoma with BRAF mutations spreading to regional lymph nodes, and the other one is more of a follicular thyroid carcinoma. It's just that it has some nuclear changes, but we treat patients and not nuclear changes. So this is going to change, and hopefully we can drive this even further in the future. As you know, we also have improved the risk stratification of thyroid cancer. We now have detailed subtyping, and for those who have read the ATA guidelines of 2025 that were published just a month ago, I think, you could see that even microcarcinomas with a specific subtype should be treated and regarded as intermediate risk and not low risk. So we're doing a lot to improve the risk stratification and prognostication for our patients. Also, we're moving along in the field of adrenal tumors, mostly highlighted by CYP11B2 immunohistochemistry, which is a game changer when you diagnose primary aldosteronism. To me, this is not possible to continue to diagnose primary aldosteronism without this antibody in clinical routine. And of course, you have the separation of NET G3 and NEC lesions into two different clinically meaningful categories. So endocrine pathology demands more of the pathologist, but it gives you so much more to the patient and the clinical team. So with that said, the focus of this lecture today is parathyroid tumors and the current dilemmas that we face. Firstly, a short background, followed by one of the most classical enigmas, the carcinoma versus atypical tumors, and also how we can override this by using information from the clinics and also biomarkers. And finally, I will talk in just a few minutes about avoiding overdiagnosis of parathyroid carcinoma, because this is a real issue, at least in my practice when I do consult cases from abroad and in other parts of Sweden. So parathyroid carcinoma, as you know, it's extremely rare. We need to always have this in mind. Parathyroid carcinoma is rare. That's the first thing that should come to your mind. It's not a diagnosis you see every day. The incidence varies with different studies, but it should be really, really low. The age peak is younger than for conventional benign hyperparathyroidism, and the gender distribution is equal as opposed to benign HPT as well. These cases, as you know, they present with severe hypercalcemia, very high levels of PTH, and they can have a palpable neck mass. And when you do the parathyroid surgery, you often find that the lesion is firmly adhesive to the thyroid bed, allowing you to do an ipsilateral thyroidectomy, lobectomy at the same time. Unfortunately for these patients, we don't have many treatment options once metastatic, and many patients die from uncontrolled hypercalcemia. So this is a case from my practice at Karolinska in Stockholm. You can see that the surgeon opted to do a ipsilateral lobectomy of the thyroid gland, but you also see a cystic parathyroid tumor that is even bigger than the thyroid lobe that we have bisected here just to show you. And to the right is the first histological image of my lecture, and this is parathyroid carcinoma metastatic to the lung. So this patient had lung metastases that were biopsied and verified as parathyroid carcinoma. So whenever you get a parathyroid tumor as a pathologist, your first issue is to resolve whether or not this is benign or malignant. First of all, is it pathological or not, of course, but then, is it malignant or benign? And we do have some clear-cut malignant features. And it sounds really simple when you put them like this in a table. Angioinvasive areas, lymphatic invasion, perineural, all types of invasion, or metastatic disease. Of course, that would classify as a parathyroid carcinoma. The only problem is this is not straightforward. There are many mimickers of angioinvasion that you need to keep in your head when you do this. So you can have many false positives if you're not careful enough. Once you have ruled out all these clear-cut malignant features, well, you still have the option to designate a diagnosis of atypical parathyroid tumor, which are tumors that have several atypical criteria, but they do not classify as carcinoma. And these criteria may not only be histological criteria, they might be clinical criteria as well. So I always ask my residents for the clinical background, because I don't only see the slide, I would like to see the background of the patient, because those criteria might also be atypical. So you really need to fit all these different aspects before you make the final diagnosis. Here's an atypical parathyroid tumor at Karolinska. To the left is an immunohistochemical stain called Ki67, which labels proliferating cells, and you can see the brown ones are proliferating ones, and this is a very high Ki67 index, around 10%. And to the right, you can see an area of a capsular invasion. This does not classify as parathyroid carcinoma, but it's an atypical feature, and it's worrisome for malignancy. In the WHO classification, we listed quite a few criteria for an atypical parathyroid tumor, and these are histological ones, but also, please note that we also incorporated biomarkers here. Parafibromin and other biomarkers are also needed to make the final call. So it's no longer a histological diagnosis only. You need also immunohistochemical workup of these lesions. And to be honest, you can also put clinical parameters in here, such as elevated biochemistry and so forth. And of course, atypical tumors should not have any of the following findings, because these ones would signify a carcinoma. So it's a combined effort in which you merge biochemistry, clinical information, of course the gland, the weight of the tumor, atypical features, invasive features, and also, of course, my baby, parafibromin, immunohistochemistry. I will come back to that later. And even further, you can go into the CDC73 genotype, CDC73 being the gene encoding for parafibromin. So what is parafibromin? Well, to understand what parafibromin is, you need to understand what is the HPT-JT syndrome, which was a syndrome originally with hyperparathyroidism in which tumors were often malignant. 15 to 20% of patients with this syndrome develop parathyroid carcinoma, but 80% develop adenoma. And they also develop specific lesions of the jaw. It's an autosomal dominant disorder, and it was discovered through investigations by my old professor Katarina Larsson at Karolinska. It was cloned as the HRPT2 gene, which means hyperparathyroidism type 2, because then MEN1 was hyperparathyroidism type 1. It later changed name to CDC73, which is more biologically correct. This gene encodes parafibromin. So once we knew that mutations in this gene caused this syndrome with parathyroid adenoma, carcinoma, and also fibrosis jaw tumors, it was then established that parathyroid tumors with these gene mutations often displayed lack of parafibromin expression. And this was shown by immunohistochemistry. So in reality, although you only have one mutation in these families, the second allele is lost due to a sporadic mutation or loss of heterozygosity. So it's a biallelic Knudsen hypothesis in activation of a tumor suppressor. What happened after that was a joint collaboration between Connecticut and Karolinska, in which, again, my professor Katarina Larsson discovered that the majority of sporadic parathyroid carcinomas harbored CDC73 gene mutations that were somatic, meaning that this gene is super important to the development of parathyroid cancer. And this was published in New England Journal of Medicine. Following this study, a lot of different studies have shown that this is true. The majority of carcinomas, 50 to 70%, so to speak, have mutations or deletions of this gene, and they lose parafibromin expression. Subsequent studies on atypical tumors show that a few atypical tumors also have CDC73 gene mutation, but it's almost never found in adenomas, with a few exceptions. So we're going to go a bit molecular here, but bear with me, this is just one slide. So basically, to the left is the wild type status in a normal parathyroid cell, and to the right is the mutated state in a parathyroid carcinoma or atypical adenoma. Parafibromin inhibits the expression of specific oncogenes called cyclin D1 and c-Myc, which allows apoptosis to happen, and it also inhibits the cell cycle through PRB, which is the retinoblastoma protein. Once parafibromin is lost, the repression is lifted from c-Myc and the cyclin D1 promoter, and they start to express themselves, leading to a reduced apoptosis and inhibition of the very important tumor suppressor RB, leading to cell cycle activation. This is the molecular background to how parafibromin acts on the cellular level. So you can have either loss of the entire gene copy, or you could have point mutations. The most commonly mutations are frame shifts alterations, causing a truncated protein, but you also have missense mutations in hotspot regions. Irrespectively of what type of inactivation method you have, parathyroid carcinomas that have these mutations, they are very different from the ones that do not. Please bear in mind that 30% of carcinomas do not have parafibromin mutations. So if you have a mutation, you have higher tumor mutational burden, increased copy number alterations, and a higher risk of recurrence. So parathyroid carcinoma is, with loss of parafibromin, it's worse than to have a diffuse parafibromin expression. So it's also prognostic for carcinomas. So this is where I started with my PhD studies when I arrived at Katarina Larsson's lab to develop parafibromin immunohistochemistry. And I wasn't the first. There were other groups doing the same thing, but we developed different antibodies looking at different parts of the protein. We found, of course, similar to other groups in the UK and the US and Australia, that positive nuclear staining was very highly indicative of a wild-type gene. We found that adenomas were almost always positive, but there were sporadic cases with mutations that on long-term follow-up did not have any recurrences. So there is probably a small subset of adenomas, usually they have cystic features, that are allowed to have these mutations and still not progress to cancer. And we also saw a few atypical parathyroid tumors with loss of parafibromin, and when they were negative, these cases had a real recurrence risk, and some of them recurred as bona fide carcinomas. So the brown staining here indicates parafibromin. This is an antibody towards parafibromin. You can clearly see that this is a parathyroid adenoma with clear-cut expression, whereas in this parathyroid carcinoma, you have a negative expression in the tumor tissue to the right, but the normal rim, which is the normal tissue to the left, is positive, acting as an internal control. So this is a CDC73 gene mutated parathyroid carcinoma. However, not all cases are straightforward. This is a pattern that we saw recurrently. You have a reduced expression, but no total absence. This is a CDC73 gene mutated atypical parathyroid tumor. It has a partial loss in which some nuclei are clearly negative and some are not. And to add to the confusion, we have also published cases of loss of nucleolar parafibromin. And the nucleolar compartment usually contains the ribosomal RNA. And it's the small blue dot that you see centrally in the nuclei. And it's unstained. And this case harbored a specific mutation within CDC73 in the region encoding the nucleolar localization signal. So in certain HPT-JT families, they might harbor a mutation within this sequence, and then parafibromin is not able to go all the way into the nucleolar compartment, and hence you have nucleolar loss. So this mandates 400x investigation. You can't just breeze through the slide and look at it very quickly. You need to really go into depth and look at these areas as well. How should a pathologist not use parafibromin? Well, this is fairly simple. Like, if you diagnose 1,000 consecutive cases in clinical routine, more or less the vast majority will of course be benign adenomas. Say 10 to 15 will be atypical tumors, and 5 to 10 will be carcinomas. So I can sit and guess at my desk and I will be right very often. So, but bear in mind that if you do the numbers, 0.1% of adenomas, and these are adenomas, they never occur, they have loss of parafibromin. And on 1/3 of atypical tumors and the majority of carcinomas. But if you stain these 1,000 cases blindly for parafibromin, well, then you would end up with more adenomas than carcinomas showing loss, so you have a problem. So you can't rely on parafibromin as the sole indication of carcinoma, because it's not. It could indicate an underlying CDC73 gene mutation, and that is important because we have discovered Swedish cases that are HPT-JT syndrome patients, but they do not have cancer. So from the establishment of CDC73 gene mutations all the way to clinical routine analysis in 7 years, and we've been using the marker ever since. It's a great addition, but it's not enough in all cases, unfortunately, which I will come back to in the following slides. This is the algorithm that we presented in the WHO 22 overview paper in endocrine pathology, and this is how we would like endocrine pathologists and pathologists in general in the world to use parafibromin. So the first thing you do is that you diagnose the tumor as either benign, atypical, or carcinoma. And do not look at parafibromin, because this you should be able to do using histology and other biomarkers maybe, but the definition of carcinoma is based on H&E. Then you stain for parafibromin. If you want to, you stain adenomas. I rarely stain adenomas unless they are MEN1 negative cases in very young patients, but it happens. And then it could inform you whether or not to go on with constitutional gene testing. Parathyroid carcinomas, I always stain them, of course, because it's part of the workup, but irrespectively of parafibromin being lost or not, it's a prognostic marker if it's lost, but they should still undergo CDC73 gene sequencing, because bear in mind this might be a syndromic case. The true value of parafibromin are the atypical parathyroid tumors in the center. These are the guys that you'll be looking for with parafibromin, because if you have a parafibromin positive atypical tumor, the risk of recurrence is super low. It's not zero, but it's super low. We advocate some sort of follow-up, but it's very low. However, if you have a parafibromin deficient atypical tumor, this could be a carcinoma in disguise, so to speak. So these ones you should really follow, and also, of course, perform the constitutional gene sequencing. If your center does not have parafibromin, or do not send cases to someone who can stain it for you, there are some histological correlates, which is really nice. This was published by my friend Tony Gill in Sydney recently, and they found that there are some histological correlates to underlying mutations and loss of parafibromin. And I'm not going to go into detail, but I will just show you one image. So these are very eosinophilic tumor cells with something called a halo around the nuclei. You can see the white area around the nuclei, and this is fairly specific to parafibromin deficient tumors. And this is a Karolinska case, so I verified this. It's actually true. It holds up. And we can do the same with SDHB in pheochromocytoma and paraganglioma, and this is fairly similar. So it's always an indication. I would still stain it if it was atypical, of course, but even though it's a nice treat. And here's the subsequent parafibromin stain of the same case. Negative, and the patient had a germline mutation. We do have additional biomarkers as well. And I think it's important to know that it's not only restricted to parafibromin. We have a few of them have been worked up by my lab, and a few of them are from older studies, but you can use combinations of these. And we recommend that you throw everything you have at these atypical tumors in trying to elucidate whether or not they are carcinomas or not. So loss of APC has been found recurrently in carcinomas, but is almost never negative in adenomas. And this is quite a nice marker, because it also stains HPT-JT related adenomas as positive. So if you have a tumor with loss of parafibromin, because it's a syndromic case but it's still benign, APC will be positive, whereas in carcinomas it's negative. It's always nice to have a marker that shows overexpression and not only loss of expression, because sometimes you can lose the antigenicity in the tissue due to different factors. So PGP 9.5 is a marker that is recurrently overexpressed in atypical tumors that recur in carcinomas. So in my practice, I teach my residents that we need parafibromin, PGP 9.5, APC. We also use galectin-3 for some reason. It's not as validated as the other markers, but we need as many as we can. And also, of course, the Ki67 index, because that could really tell you something. And this is super important because if the biomarkers tell you something and the histology says something else, then you have a conflict and you need to sort out whether or not this is a typical tumor or not. And this leads into my final aspect of this talk, which is the overdiagnosis of carcinoma. And this is a real issue, unfortunately. It's like if you overdiagnose carcinoma, these patients will be followed and they will have a lifelong worry for recurrences. So you need to be really careful what you're doing here. And you need to collect all of these different points of information. You need to know whether or not there has been previous manipulation of the gland. Has there been a fine needle aspiration biopsy taken? Then I would be very reluctant to call something carcinoma or even a typical tumor unless the biomarker profile really screams carcinoma. Has the tumor been bisected in the OR? Which please don't. If you don't have to, please don't, because it really messes up the histology and it makes the tumor cells go outside the capsule and even into the fat, and it looks really scary and worrisome for carcinoma. Peleosis is extravasation of erythrocytes. It's very common in parathyroid tumor. It means that the tumor cells are bathing in erythrocytes, but it's not true vascular invasion. I will show you how it looks like in the following slide. We heard some earlier talks today about parathyromatosis and the use of parafibromin. The seeding of benign parathyroid tissue is an issue, and it could lead to overdiagnosis of cancer. And of course, always intrathyroidal tumors are really hard sometimes to diagnose because they might have a very messy appearance and very hard to tell apart from true invasion of the thyroid bed. So integrate clinical, biochemical, intraoperative, histological, and biomarker profiles. And please talk to the pathologist in charge if you have information that might lead to a different diagnosis. So this is a secondary consult case from another hospital in Sweden in which they diagnosed carcinoma due to, and I quote, extensive vascular invasion infiltrates, end of quote. And you can see to the left that this looks like worrisome for vascular invasion. But if you do the immunohistochemical markup, which is in this a double stain, in which tumor cells are stained red and the endothelial layer is stained brown, you can see that there is no endothelial layer in these areas. So this is false. This is due to peleosis. So I recurrently use endothelial markers to rule out vascular invasion. This is a case with a previous fine needle aspiration biopsy to a neck mass, and you can see fibrotic tissue in the dead center that causes worrisome appearance. So fibrosis is a typical finding, and also you have a mess in the right image. You can see that these parathyroid tumor cells are intermingling with normal thyrocytes and also adipose tissue. So it causes a lot of confusion whether or not this is real invasion or not. But in this case, the biomarker profile was 100% benign, parafibromin was positive, Ki67 was less than 0.1%, and all the other biomarkers screamed adenoma. So in this case, you would never diagnose this as cancer. So this is ongoing work. It's in press right now. It's a review article in which me and my colleague in Canada tried to highlight a way forward for the atypical parathyroid tumors. And I'm sorry for the busy slide, but I just wanted to send the message that if you have an atypical parathyroid tumor, this should lead to a lot of different things happening in the pathology lab. Is the tumor embedded in toto? Does it mean that everything is embedded, or is there still something left in the jar? Have you used multiple levels? Did you cut this in multiple levels and looked at it in all aspects? Did you do the biomarker workup? And are there signs of previous manipulation? And you can see if there are signs of previous manipulation and there are no biomarker abnormality, we call this adenoma. So once you end up with a true atypical tumor diagnosis, then you do parafibromin, then you decide whether or not they should undergo CDC73 gene testing and whether or not the risk of recurrence is real or not. So I would say parathyroid carcinoma is a diagnosis that requires comprehensive workup. A typical tumor should not be a wastebasket diagnosis. You need several worrisome features and the correct biomarker profile. And please note that if you have an APT with loss of parafibromin, that could well be cancer in disguise. A final slide before take-home messages. Molecular testing, where are we at in parathyroid carcinoma? Well, as you know, we only have modest responses using cytotoxic drugs for these lesions once they disseminate. There are some case series in which they suggest activity using tyrosine kinase inhibitors, but all these data are non-randomized, of course, because there are so few these cases. What we do know is that when you do NGS testing somatically of parathyroid carcinoma, there is a large subset of cases that will have mutations in actionable genes, such as in the ACT, mTOR, PIK3CA pathway. And these are potentially targetable. So if there are no other options available and you have a good NGS platform, I would submit this tissue for NGS testing right away, because you might be lucky in this aspect. Of course, data is lacking of how efficient this would be in real life, but it still provides some glimpse of hope for this patient category. So my take-home messages. Endocrine pathology, of course, is here to stay, and we're developing this subspecialty, hopefully for the better of the patients. Please bear in mind that parathyroid histology is 99% a breeze and 1% total chaos, and that's when you have a carcinoma, and that's when you need us the most. So please have patience with us and know that this is a really hard diagnostic workup that require integration of so many different aspects. It's not only H&E and pink and blue. And of course, parafibromin is a game changer, so if you don't have this in your pathology lab, please convince your pathologist to get it as soon as possible. Of course, thank you so much to the British Journal of Surgery for having me as a lecturer. Alison, of course, where are you? Thank you for having me, and also Ms. Patel for arranging everything. All my members at the research team. You can see my Twitter handle if you want to follow me. I do these silly pathology tutorials for residents, but it might be fun for you guys as well. And you have my email address if you want to contact me further. And that's it. Thank you so much.